All right, here we go. Hello, and thank you for watching this program on the best rehab codes. There's no audio taping or videotaping allowed, in any unauthorized reproduction, dispensing, forwarding, or copying of this presentation is illegal. The information contained in this presentation is for educational purposes. It should not be construed as a substitute for your thorough clinical decision making. This information is not legal advice. We don't provide legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. A little bit about myself. My name is Dr. Marty Kotler. I'm a chiropractor. I practiced for 16 years, and about 12 years ago, I started a company called Target Coding. I'm certified in CPT coding. I'm a certified professional compliance officer. We help thousands of chiropractors with CPT and ICD-10 coding. Our areas of expertise include Medicare compliance, HIPAA compliance, creating billing and coding policy and procedure manuals, record keeping, treatment plans, and helping doctors put together compliant cash plans. I've written many books and put together many training videos on chiropractic documentation, billing, and coding. I write articles for Chiropractic Economics, Dynamic Chiropractic, the American Chiropractor, and for many state association newsletters. I also write articles for the American Academy of Professional Coders. So that's just a little bit about myself. Now, let's dig in and talk about the best rehab codes, also known as therapeutic procedures. So the definition of therapeutic procedures is the manner of effecting change through the application of clinical skills and/or services that attempt to improve function. One-on-one patient contact is required, one or more areas each 15 minutes. So a few things here. Application of clinical skills. When you are providing a rehab service, you need to be applying a clinical skill. What is a clinical skill? Well, think about it. If a patient is doing some sort of rehab procedure and the doctor or staff member in certain states, staff members cannot oversee rehab procedures. So you're going to want to make sure that whoever's overseeing these therapeutic procedures and providing them is allowed to perform them in your state. Most states allow chiropractic assistants to oversee therapeutic procedures. So whoever's overseeing the therapeutic procedures while the patient is doing it, you need to be applying clinical skills. An example would be to give a patient verbal cues, hands on the patient, instructing him on how to perform the exercise, getting feedback from the patient, possibly adjusting the exercise that the patient is doing. I'm going to give you more examples as we go through some of these codes. One-on-one contact is required. That means it's a time-based code, one-on-one contact. It's not necessarily constant. For example, you could do a rehab procedure for 5 minutes, one-on-one, and then you could walk away if you feel the patient is safe and secure and have them continue to exercise for another 5 minutes, and then you come back after 5 minutes, and now you're with the patient for 3 more minutes of one-on-one. The total time that you were with the patient was 8 minutes. The 5 minutes that you walked away doesn't count. So these are a couple of the things that I want to set the table here for the therapeutic procedures. Another thing I want to set the table before we get into the codes is the difference between wellness care and medical necessity. Many providers have had some problems getting paid for therapeutic procedures. And one of the things that come up is the carriers will say, well, we reviewed your documentation, and based on the documentation, we don't feel the care is medically necessary. So they might not pay you, or if they paid you, they may want the money back. So what constitutes medical necessity? Well, a couple of things here you should see on your screen. Medical necessity equals insurance payable, right? That's to me, that's a very simple equation. Just think about it when let's say a patient calls to verify coverage. Say Mrs. Jones calls her insurance company and says, does my policy cover chiropractic services? 99% of the time, this is what the patient is going to hear from the insurance rep. Yes, chiropractic is covered as long as it's medically necessary. So medically necessary means insurance payable. Chiropractic wellness care, maintenance care, that's not payable. Active treatment, if you see Medicare patients, make sure you know what active treatment is. That's medically necessary. Patients with pain, restricted motion, decreased ability to do their normal activities of daily living, that's insurance payable. Very little pain, range of motion is great, patient could do most of their ADLs, that's not payable anymore. So not medically necessary means not insurance payable. Performance enhancing care, yes. I had patients coming into my practice saying, hey, Dr. Kotler, I heard you're really good with my friends that play golf. I want to hit the ball further. I tee off, I hit the ball 200 yards. I want to hit the ball 225 yards. I heard you could, work on my back and make me hit the ball further. That's not payable by insurance to help the patient hit the ball further. So the goal is to get the patient better as fast as possible. I call it achieving maximum therapeutic benefit, and then transfer them to wellness care. So medical necessity, again, it's, what is it? It depends who you ask. When I first started practicing, medical necessity to me was I give the patient a chiropractic adjustment because they need it based on my evaluation. Well, that doesn't work anymore. So again, it depends who you ask. If you ask Aetna, yeah, here's Aetna's policy. Aetna considers chiropractic services medically necessary when all of the following criteria are met. The patient has a neuromusculoskeletal disorder. The medical necessity for treatment is clearly documented. Improvement is documented within the initial 2 weeks of care. If no improvement is documented within the 2 weeks, the chiropractic treatment should be changed. Something should be modified. And if still no improvement is documented within 30 days, despite modification, care is not medically necessary. So just keep that in mind, especially when billing Aetna patients. They have some more information on medical necessity. You can get this online. It's pretty easy. You could just Google Aetna's policy on chiropractic. Now, who can provide the services? I touched on this a few minutes ago. There's two categories, in my opinion, of providers and members of a staff and doctor's office. So a QHP, a qualified healthcare professional, is an individual who's qualified by education, training, and licensing, who performs a service, and that could be reported to an insurance company. You can bill an insurance company. That's different than a clinical staff member. A clinical staff member is a person who works under the supervision of a chiropractor or a PT or medical doctor or other qualified healthcare professional who is allowed by law to assist and help perform the service but cannot individually report that professional service. Make sure you know who are QHPs versus clinical staff members in your practice and find out in your state. I can give you a quick example. In the state of New York, CAs, which would be considered a clinical staff member, a chiropractic assistant, cannot perform any therapies. That's just the way it is in New York. CAs cannot perform any services. CAs in New York cannot even put a hot pack on a patient. So just want to make sure that you are following the laws and the rules. And I say this all the time. You have to know the rules in order to know if you're following them or breaking them, right? So, all right, here we go with our first one, 97110. One of the best codes, one of the easiest codes to implement, in my opinion. If you're typically incorporating rehab, you're probably billing 97110. If you've been using 97110, you're probably getting paid nicely. It's an excellent code. If you have never incorporated, we have a lot of people listening to this presentation. Quite a few of you have been just doing straight chiropractic and just doing maybe a couple of modalities, and now you're thinking about incorporating therapeutic exercises. So here we go. This is how it works. 97110 is a therapeutic procedure. specifically therapeutic exercises used to develop strength, endurance, range of motion, and flexibility. Yeah, there's an acronym. You might want to write this down. SERF, S-E-R-F. S stands for strength, E stands for endurance, R stands for range of motion, and F stands for flexibility. You need to be accomplishing one of those parameters. Think of that as an intended goal for the patient, at least one of those. If you want to develop more than one and accomplish more than one, that's fine, but at least one of those: strength, endurance, range of motion, flexibility. So if your goal is to do that, what should the patient have a lack of? Yeah, strength, endurance, range of motion, flexibility. One more item: the difference between a modality and a therapeutic procedure. Think of a modality as what? Traction, electrical stim, ultrasound. Those are modalities. So the way those are billed and reported is based on the piece of equipment. Think about it. If you're going to bill a traction code like mechanical traction 97012, you need a traction device. If you have an ultrasound machine, you bill the ultrasound code. If you have an electrical stim machine, you bill the electrical stim code. So modalities are based on the device, the machine that you have. When it comes to therapeutic procedures, it's not based on equipment. It's based on your intended outcome, regardless of what equipment you're using. So therapeutic exercises could be performed in either an active, active-assisted, or passive approach. That's what most of my clients do, a little combination of active and passive. Your documentation must show the reason why you're doing it. What's the reason? The patient has loss of motion, loss of strength, loss of mobility. Can the patient perform the exercises without the application of skilled assistance? Remember, application of clinical skills. You need to document what application of skills you are providing. Next, 97112, neuromuscular reeducation of movement, balance, coordination, kinesthetic sense, posture and or proprioception for sitting and or standing activities. Very nice code. Most insurance companies will pay chiropractors for this service. Most insurance companies pay physical therapists for this service. Let me point out, every plan that you're billing, we're talking about Aetna, Cigna, United Healthcare, Blue Cross Blue Shield, all of your PI carrier, State Farm, you need to check with them to see what their policy is on these codes. Don't assume that the way you're doing it is okay with the insurance company. It's a different approach when you're treating a cash patient. If you're billing an insurance company for 97112, find out what their policy is on this service. So this is used to improve balance, coordination, kinesthetic sense, proprioception. So if you're using it to improve balance and kinesthetic sense and proprioception, what should the patient have a lack of? Yes, you got it. Balance, proprioception, document that, create that. I call it a breadcrumb trail. So here's a quick one. Mr. Jones comes in. He's complaining of neck pain. He also feels like his balance is off. He's also got ankle problems, and he sprained his ankle. And you want to perform neuromuscular reeducation. Document that the patient has balance issues. Document that the patient has a sprained ankle, and you're going to try and improve the proprioception from his ankle up to his brain via the use of your technique, or maybe a wobble board or a balance board. Create that information, and then when you bill the code, you'll be able to justify it. Next, 97140 is manual therapy techniques. This is a combination or one or more of many things. You could do soft tissue mobilization. That counts as manual therapy techniques. Manual traction, manual lymphatic drainage. Even manipulation is on the list. What else is on the list? Myofascial release, acupressure, non-injectable trigger point therapy. Myofascial release is probably the main technique used when billing manual therapy techniques. Excellent code. Most insurance companies pay chiropractors and physical therapists for this service. Now, there's a couple of things. First, with this code, there's a CCI edit. That stands for Correct Coding Initiative, CCI. And the CCI edits for this particular code state that it cannot be performed in the same anatomic site as the chiropractic adjustment. Make sure you're aware of it. So if you're going to bill this code on the same day as a chiropractic adjustment, in order to follow the rules, you need to know the rules. The rules are the manual therapy needs to be in a separate and distinct region. You need to have a separate diagnosis. And if you want to ensure payment, you need to use the 59 modifier. If you're using the 59 modifier and you're not sure why, reevaluate your situation. It's one of the most common errors I see when I review doctors' notes is that, and their bills, I see many doctors using the 59 modifier on codes that don't need it, like traction, mechanical traction on the same day as an adjustment. You don't need the 59. I see chiropractors using the 59 on 97110 on the same day as an adjustment. It's not necessary. It actually can hurt you. An excessive use of the 59 modifier will trigger an audit. Now, when you're performing one of these therapeutic procedures, it's a good idea to match these CPT codes with an appropriate diagnosis code. I call it code pairing, like pairing wine and food. So pair myofascial pain syndrome, that's a diagnosis, a herniated disc, bursitis of the hip. Those three ICD-10 codes match beautifully and pair beautifully with manual therapy. Another example is you want to perform therapeutic exercises. There are certain diagnosis codes that make a tremendous amount of sense when billing therapeutic exercises, like sciatica, a stiff shoulder, a strained quadricep muscle. So again, a little bit more about ICD-10 and justification. So if you're going to diagnose a patient with sacroiliac sprain or sacroiliac subluxation or sacroiliitis, something to do with the sacroiliac joint, because you want to be able to bill for one of the therapeutic procedure codes, start building your case. So if you're ever questioned, so Dr. Kotler, why did you or how did you diagnose a patient with sacroiliac sprain? What was your clinical rationale for doing it? Hopefully you'll say, well, the patient had pain in the SI joint. I did Yeomans and Ganslins and Faber-Patrick. Do a couple of ortho-neuro tests to substantiate it. You'll be able to sleep much better at night, and you'll be able to justify any issues that might come up in a state board case, a malpractice case, or an insurance audit. Cervical radiculopathy, that's another pretty common chiropractic diagnosis that could match beautifully with therapeutic procedures. But if you're going to diagnose a cervical radiculopathy and you're questioned, hey, Dr. Kotler, how did you come up with cervical radiculopathy? Well, the patient had pain in the neck. It was radiating down into an upper extremity. I did Jackson compression. I did shoulder depression, Sperling. There was some myotomal weakness. I checked reflexes. There was limited motion in the neck and segmental dysfunction, subluxation. I have x-rays that show degeneration of the disc, or I have an MRI that shows a herniated. See how nice? That's how you prove what you're diagnosing is correct. That's how you create that breadcrumb trail if anybody comes snooping around. Oh yeah, this is a page out of a book that I recommend that gives a nice bunch of very common chiropractic diagnosis codes, and then the affiliated ortho, neuro, and chiro tests to substantiate it. There's another example there at the bottom. If you're going to diagnose a patient with M53.1, that's cervicobrachial syndrome, do Wrights, do Atsons, check some reflexes, look for, weakness in muscles. Does the patient have forward head posture, rounded shoulders, scapular winging? Oh, while we're talking about ICD-10, let me just give you a little update on October 1st. Every year on October 1st, the ICD-10 codes get updated. There were about 350 new codes added, about 150 deleted, about another 100 or so that were revised. I've reviewed the list. Very, very, very few relate to typical chiropractic practice. To me, this is the main one that you should be aware of. M48.06 is lumbar spinal stenosis. That code is still valid. However, it got more specific. M48.061 is lumbar spinal stenosis without neurogenic claudication. M48.062 is lumbar spinal stenosis with neurogenic claudication. So don't use M48.06 anymore. It's either 061 or 062. Now, this is what has been happening when I've been explaining this code to my clients. And these came out back in, I think back in July or August. So I've been giving my clients a heads up on this code. And then, I have doctors that I work with in practice 5 years, 10 years. Some are in practice 20, 25 years, and they didn't know what neurogenic claudication is. That's okay. That's all right. So that's why I've supplied you with, just in case you were wondering, what the heck is neurogenic claudication? Neurogenic means it's coming from the nerve system. Claudication means there's heaviness and pain with walking, weakness in the legs. Don't confuse that with intermittent claudication, which is more of a vascular issue, which is caused by impaired blood flow to the leg muscles. Okay, now we have 97530, therapeutic activities. This code is more complicated, but it pays more. It has the highest RVU out of the 4 main ones that I went through. Therapeutic activities, direct one-on-one patient contact, use of dynamic activities to improve functional performance. The use of dynamic activities. What is dynamic activities? Well, it typically involves bending, lifting, reaching, carrying. The patient is doing something in your office that helps improve bending, lifting, reaching, carrying. That's why a lot of people call this the ING code. It's a multi-parameter code. Document clear correlation between the type of therapeutic activity performed and the patient's underlying condition. Big difference between 97110 and 97530. Now, these codes are all time-based. What's your office policy on time-based codes, how to build them? You should have an office policy, some sort of billing and coding manual that describes all these things. So just in case somebody comes snooping around, you could say, whoa, wait, here. It's like if you get pulled over, by a police officer, what do they want to see? They want to see your license, registration, and insurance card. If you don't have those things, you're going to have a problem. If you have them, you show them and you move on. If you get pulled over by an insurance company, a malpractice case, or a state board, they're going to ask you for your license, registration, and insurance card. All of that is built into your office billing and coding policy manual. So you should have one and include what is your policy on billing for time-based codes. This is what it should be. For total time, insurance companies that use total time, there are 2 schools of thought. Total time and rule of 8. Total time is where 8 to 22 minutes is 1 unit, 23 to 37 minutes is 2 units, and on and on. So let me give you an example. In total time, if you do 23 minutes of manual therapy and 23 minutes of therapeutic exercise, what's the total? 46 minutes. You can only bill 3 units, not 4. At a quick glance, you would think, wait, 23 minutes, that's 2 units. And then another 23 minutes, well, that's another 2 units. I should be able to bill 4. No, you cannot do that. Now, if you get to 30 minutes of 140 and 23 minutes of 110, that totals 53, then you can do it. Now, some health plans use what I call the rule of 8, whereby you could do 8 minutes of one service, follow it with another 8 minutes of another service for a total of 16 minutes, and you can bill both codes. So make sure you know which carriers use total time and rule of 8. Put that in your policy manual. Here's another thing that I want to share with you. I used 97110 as the example here. There's a big difference between creating your care plan and a individual SOAP note. When creating a care plan, lay out the whole story by saying the initial 12 visits will include therapeutic exercises with direct one-on-one contact. Lay it out. This way, if you're ever questioned, you can say, wait a second, take a look at my notes. It's there. Wait a second, police officer, here's my license and my registration here. I got everything. There's no issues. So the initial 12 visits will include therapeutic exercises with direct one-on-one contact in both the active assisted and passive approaches. Again, that's something you have to decide, whether it's active assisted or passive or both. And the reason, what's the clinical rationale? In this example, to increase range of motion. The exercises will be performed and explain your protocol, whether it's hands-on or you're using balls, bands, tubes, weight machines. Lay it all out in the care plan, and then in the SOAP note, it's simple. Exercises, low back, 15 minutes. I don't get why some doctors, when I read their notes, their SOAP note is 7 pages of just fluff. It's just information that their software just puts in as cookie cutter, carrying forward, cloning information. I've seen some notes where it's 7 pages, but if I boiled it down just to what was different from the previous visit, it would probably be 1 paragraph out of the 7 pages. So, little heads up on SOAP notes versus care plan. Oh, and I mentioned a billing and coding policy. Yes, I strongly recommend. Nowadays, it's more important than ever to have a billing and coding policy manual laying out, how we allow staff members to access our systems, and that, you do every, maybe twice a year, you take out a few charts and do an internal review. We've put together a little chart audit tool, and you just go down the list. Go find Mrs. Jones' file, take it out, take out a SOAP note, take out the first visit, and start asking yourself questions. This is the honor system. You're going to be grading yourself. You're going to be giving yourself good grades, I'm assuming. So, but make sure the information's there. We have a checklist here. Simple stuff. Is the patient's name and date on the form? Yes. Areas of tenderness palpated? Yes. Areas of subluxation? Yes. Do I have short-term goals and long-term goals? Well, maybe it's not applicable for this patient. So you could put NA. So you go down the list and then you grade yourself. In this example, 32 questions were asked. 29 out of 32 were answered yes. This equates to 90%, or an A. 29 divided by 32 times 100 is 90, so A is 90 to 100. And keep going with a few chart audits. Again, twice a year. If you see Medicare patients, you should do what we call an OIG exclusion list check. So go into this website and put in your name and see if you come up. Hopefully your name does not come up on the excluded list. So this is just part of basic billing and coding manual. Here's, many of you adjust full spine. I know you do. You adjust full spine, but you only bill 98940. Whoa, what's the deal there? Right? A patient could come in with neck pain. That's it. All they have is neck pain, and maybe you use activator or you adjust full spine. I did that with just about every patient. Even though the patient's only complaint was neck pain, I checked the thoracic. I checked their leg lengths. I would adjust their lower back, even though they didn't have any complaints. What's your policy on that? If you don't have a policy on that, you could be accused of undercoding. So we have a policy here. We analyze the entire spine. During most encounters, we perform chiropractic adjustments on medically necessary regions, as well as on regions for supportive maintenance. We only bill for medically necessary services. And yeah, here's a little complete, checklist. So 2 times a year, we'll check our notes. 1 time a year, we do a staff training on this. 3 hours per year, we do this. Security risk is done once a year. It's nice having a little calendar, a checklist. So these are just basic policies. If for some reason there's a breach, hopefully you never have a breach of your patient files, but here's a little action step that would take, do you have a policy? Yeah, a couple of years ago, a client of mine says, Marty, my staff are driving me crazy. Every time I turn around, they're on their cell phones. They're doing something. I don't know if it's work related or what, but they're always on their cell phones. It's driving me crazy. So I put together a cell phone use policy. If you see Medicare patients, put together a little policy on how you incorporate the ABN form. Okay, so back to the therapeutic procedures. Let me show you a claim here. So if you take a look at the second line item, you'll see 97140 with a 59 modifier, and that's pointing to a separate anatomic site than the chiropractic adjustment. That's why I have the 59 modifier. That's why I have a separate diagnosis, and that meets the CCI edit rule. And then you'll see on the fourth line item, 97110, that's pointing to box 21, A and B, which are two lumbar diagnosis codes. So I'm doing the chiropractic adjustment on the lumbars, doing the manual therapy on the cervical, I'm doing the electrical stim on the thoracic, and I'm doing the therapeutic exercises on the lumbar region. So that's what we call diagnosis pointing. Alrighty, just a few closing comments. Please check with the carriers your bill prior to submitting claims based on this presentation to ensure that it is compliant. Target coding does not guarantee that this information will guarantee payment from any patient or insurance company. Target coding is not responsible for any changes that occur. Please understand changes occur all the time. It's important to do your best to stay on top of these changes, attend seminars, webinars, join your national and state professional associations. Here's our contact information. Email info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. We've created a HIPAA secure fax number because we have doctors and staff members from across the country faxing us patient protected health information. So for HIPAA purposes, we have a HIPAA secure fax number. This way, if you want to send us any patient information, you don't have to worry about whiting out or blacking out the patient names. It's secure. So our HIPAA secure fax number is 1-844-831-2347. If you're going to send us stuff to review, if you're going to send us patient information to review, do not, I repeat, do not attach it in a regular email over like a Gmail and attach patient records, claims, notes. That's a classic HIPAA violation. Alrighty. Oh, so let me tell you, we offer a billing and coding compliance manual. As I mentioned earlier, it's a great idea to have one. It's great for your staff because they want to have organization. They want to have proper leadership. They want to be in an environment that creates a culture of compliance. So having a billing and coding policy manual is great for staff. It's great for insurance companies or state boards that come snooping around, so you could show it to them and go, hey, this is what we do. It's good for you as the provider. It keeps you focused. It'll help you sleep well at night. So we've put together a billing and coding compliance manual. If you don't have one, I strongly recommend you put one together or have us do it for you. It includes a comprehensive, customizable chiropractic billing and coding compliance manual where we give you the billing and coding policies and procedures personalized for your practice after a phone interview. We give you all the employee training logs and forms, the chart audit tools, compliance checklists and calendars. We give you updates. So you might be interested in that. We also offer a Medicare. This is a little different. A Medicare, if you see Medicare patients, it's mandatory. So a Medicare billing and coding compliance manual is something we offer. It's similar to the general billing and coding policy manual. If you see Medicare patients, this one covers all billing and coding policies. If you don't see Medicare patients, you could just have a generic billing and coding policy manual. So we offer that. Now, back to the rehab codes that we went through. This is the book. I mentioned earlier a book that has the ortho, neuro, chiro recommendations for certain diagnosis codes. So that's here in the book. This is the page I showed earlier. There's also a book. In the book are these great cheat sheets on, these are for PI, shows you the diagnosis codes that are considered long-term treatment diagnosis codes. And this section of the book shows you how to pair. Remember the wine and food pairing? This shows you how to pair the rehab codes to the most appropriate diagnosis codes. So I just wanted to show you that. Also, we also offer HIPAA compliance manuals. Now, do you need one? Maybe, maybe not. How do you know if you need a HIPAA compliance manual? You may not need one. So, HIPAA compliance is needed if you're a covered entity. Wait a second, Dr. Kotler, I don't know. Am I a covered entity? Well, let's see. I'm going to ask you two questions. Question one, do you bill or receive payment from insurance companies? If you answer yes, you are a covered entity. Therefore, you need to abide by the federal HIPAA laws. Question two, do you submit claims electronically? If you answer yes, you're a covered entity. Now, back to question one. Do you bill or receive payment from insurance companies? Let's say you say no. Okay, you're halfway there. If you say, and then I ask, do you submit claims electronically? You say, no, I don't. Well, you may not be required to have a HIPAA compliance plan. And I get those questions all the time. Hey, Dr. Kotler, I'm an all-cash practice. Do I need to abide by HIPAA? Or, Marty, I use a billing company. I don't have anything on my computers regarding my patient information. I use a billing company. They do everything, or everything's in the cloud. Or, you know what, Dr. Kotler? I am a sole practitioner. I don't have any employees. I don't need to be HIPAA compliant, do I? So just, you may want to contact us to see if you do not think, I could tell you, most chiropractors are based on those two questions. Do you bill and receive payment from insurance companies? I would say 90% of the doctors that I work with, the answer is yes. So most of you are covered entities, but some of you might be on the fence. Let us know or contact us, and we'll let you know if we think you're a covered entity. Now, some of you might say, well, yeah, I bill and receive payment from insurance companies. I have the patient sign, that new patient HIPAA notice form, and we speak quietly in the room. That means I'm HIPAA compliant, right, Dr. Kotler? No, it doesn't. So we have an outstanding HIPAA compliance program, if I may say so myself. It's different than any other one that I see on the market. Shop around. Again, here's with HIPAA, it's one of those things that you can try doing on your own if you'd like, or you could have somebody do it for you. So ours includes a comprehensive security risk analysis, which you can use towards your MIPS incentive program. Cloud-based storage portal, so everything's in the cloud digitally, and we send you everything in a hard copy binder, so you get both. Compliance training videos, business associate tracking. This includes a general billing and coding policy and procedure manual. A OIG Medicare procedure manual is included. $100,000 of cyber liability insurance is included. Oh, we also offer acupuncture consulting. We also have a acupuncture billing and coding compliance program. So let us know if you're interested in any of these items. We also do CE webinars, CE seminars coming up. We have a whole bunch coming up in 2018. We're just about finished putting together our calendar for 2018. We're going to be all over the place. We also have memberships. If you'd like to really stay connected with us on a regular basis, we have something called our base membership. That's $99 a month, and you pay as you go. Our gold membership is a one-year membership program, and you get a ton of stuff. You could just go to targetcoding.com and see all the stuff you get. The prices for this are going up in 2018, so it might be a good idea if you were thinking about doing this to hop on board now. We also have a platinum membership. So, okay, I just want to thank everybody for attending. I hope you learned a lot. Let's go and take a look and see what questions have come in now.